The following podcast is a Sempronto Media production.
Hey guys, welcome to today's episode, and I'm so excited to have Dr. Angela Cortal, and we are talking about how intermittent fasting helps with hormonal deficiencies or excesses with premenopause, perimenopause, and postmenopause. So excited to have you, Dr. Angela. Tell us a little bit about yourself.
Well, thank you. I'm so excited to be here. I am a naturopathic doctor. My practice is in Oregon, and I, over the 8 years of my practice, have been focusing on women's health, hormones, and as it relates to our physical joint musculoskeletal system. So I just love sharing the word on what we all can do as people with bodies and hormones to optimize that relationship and really improve our function and our health for as many years as possible.
You know, I just saw a friend of mine who I hadn't seen in probably about 7 months or so. And she looked amazing. Like, she just looked chiseled and she looked really, really great. And so I asked her, I said, you know, what are you doing? And she said, well, I'm doing exactly what I was doing before, except for I got my hormones checked and my hormones in balance. And she's like, I got tested and my testosterone was at 0. My progesterone was at 0. And so she's like, it's made all the difference in the world. So let's say that someone goes to the doctor and they say, okay, let's say they just go to their regular traditional doctor. I want you to talk about what test would you say that someone needs to take? Like, make sure you take, you know, because a lot of times they don't do complete tests.
Mm-hmm. Well, I would unfortunately start off by saying that someone is probably pretty lucky if they're just going to a screening or annual kind of exam and hormones even come up. I would say for a lot of us, particularly us women, things are chalked up to, oh, it's your age or the change or something like that where it's just not really investigated at all. I see that very commonly blood testing is something that's first ordered in a lot of different medical spheres. Estradiol is often a test that's used to check for estrogen because that's our main estrogen compound. Estradiol comprises about 80% of the estrogen in our body. Testosterone may or may not be looked at for some women who have PCOS, polycystic ovary syndrome. Sometimes testosterone is checked a little bit more commonly for them because they can have a testosterone excess. Progesterone is often entirely ignored unless a woman is trying to get pregnant and is not able to get pregnant. So sometimes these are checked, oftentimes they're not. I find there's some big limitations with the blood testing. And I guess as an overarching idea, the limitation is that they're not very sensitive. Someone has to be really, really high or really, really low, I find often, for us to see a significant result of the testing. And I guess the reason for that is going back to our physiology, just how our hormones are naturally working in our body. And that's that they're not just producing this even amount of progesterone day in and day out, hour in and hour out. They're really pulsatile. For women who are still having menstrual cycles, like that has a big implication there. So instead, the test that I see being a little bit more sensitive, giving us a little bit better information. Salivary testing and urine testing are additional options. Salivary testing can be really great and easy because it's literally just spitting into a little tube and sending it off to the lab. The salivary testing checks what's called our free hormones. And so all of our hormones exist as free and protein-bound states. And the free is just what free sounds like. It's out there, that testosterone or that estrogen is just floating around in our body doing its thing. The protein bound is held in these carrier proteins, like a bus escorting the hormones around. So it doesn't really have the activity. It's sort of sequestered into the protein transport. And the urine testing is actually over the last, I would say, 3, 4, 5 years, I've just transitioned to do more and more of that. I find it to be the most sensitive to get the full picture of what all the hormones are doing, in terms of the free, in terms of the protein bound, and then also with these panels, they're pretty expansive. So it's not just checking estradiol, it's checking estradiol and an E1 and E3. Estradiol is known as E2, plus everything that those are getting broken down into, plus everything upstream. So with one hormone test, we can really put together a whole map of what someone's hormones are doing, so that if I do find, for example, you were saying with your friend, like almost no or no testosterone, which I've definitely found quite a few times, we can see, well, is that because how the hormones are getting broken down is preferentially more towards estrogen, and that woman has too much estrogen and sacrificing the testosterone, or is it a deficiency really upstream and that everything is deficient?
Okay, so let me clarify, because I really know so much about thyroid because I've had so many thyroid issues. And so I feel like I'm a thyroid expert at this point, just from myself. Yeah. And so I know that if I want to go get my labs tested, I'm going to not just do my TSH, my thyroid stimulating hormone. I'm also going to check my free T3, my free T4, my reverse T3, my total T3, my total T4, my T3 uptake, my thyroglobulin antibody, and my thyroid peroxidase antibody. So those are kind of the tests that I know right off the top of my head. When I do a panel for myself, or I suggest a panel for someone, I'm saying, this is all the tests that I'm going to take. Mm-hmm. So what I just heard you say is, if someone's going to meet with you, the first thing you may say, I'll do a blood test, but sometimes the hair and saliva tests are more accurate than the blood test. Is that what I heard you say?
Yeah, that I would say, as far as if someone's going to get the testing, it's because they really want some answers. And from blood to saliva to urine, with the saliva and urine testing, you're getting the full picture. You're getting so much more. So
let's first talk about blood for just a second. So I heard you talk about estradiol. We want an estrogen total. You want to get a testosterone free in total, right? Mm-hmm. Yep, what else? Yep. What else am I missing that someone would want to? And progesterone.
Progesterone and DHEA sulfate is often used as a marker for pre-hormone production. Basically, the DHEA breaking down into those subsequent hormones.
And so, what kind of numbers would someone want to expect? So, I'll give you an example of what I mean. So, a lot of times, if you go and get your TSH checked on your blood work, if you look at what they say the lab range should be, they would say between 0.45 and 5.5, you're normal. And so for me, I feel the best when it's between 0.5 and 1.5, really between 0.5 and 1 for my TSH. That's when I'm feeling my best. So could you give listeners a little bit of kind of the optimal range, not necessarily the range that the labs say, because that's kind of the difference between functional medicine doctors the range is a lot less, and kind of on some of these, what you like to see.
Yeah, definitely. And I would say, so it's not only a maybe a smaller range or hovering towards the lower or upper end that we find optimal, but then also matching to the picture, to what someone has going on. So for example, if your friend was experiencing fatigue and muscle weakness, not really able to get through a workout, plus the low testosterone, then we're seeing with the blood testing, for example, okay, maybe the total number could perhaps be fine, but the free percentage was much lower. And so what we're really wanting to do in that case is increase the amount of free testosterone, because that's going to be what's bioavailable, what can actually circulate in someone's body and provide them what they need in terms of boosting up energy and muscle strength, muscle development, versus perhaps with progesterone. So there's a few important pieces there. The timing, like I mentioned, if someone is still having menstrual cycles, then we need to match up. Well, when do we expect the progesterone to be in a certain range for where they are in their cycle? And usually we're checking in what's called the luteal phase, the second half of the cycle, pretty much like the week before the next period happens. We're expecting the progesterone to be highest at that point. So if the question is, does this woman have low progesterone, just not spiking during that time, then that's often where we're checking timing wise, and then seeing if the progesterone comes back normal on the blood testing, but we know it's in the mid or lower range, and we really want it to be up in the kind of the top 25% of the range. Then that's what we're matching up to her clinical picture along with the estrogen. Maybe it's that the progesterone is on the lower end of the range with the estrogen on the upper end. We can call that sort of imbalance and estrogen dominance. It's not that there's an extremely high or extremely low level of either of the hormones. It's just that their ratio is so far off that the estrogen is really kind of taking over, and that we want some estrogen. It's very good. We definitely need some of it. But when it is suppressing the progesterone, especially during that last half, the luteal phase of the cycle, that's where we can see cramps and mood changes, irregular periods, summer any of that's often chalked up as like, oh, that's just premenopausal. There's often a hormonal reason behind that, and that can be a frank deficiency, or that can just be that the estrogen is at the top and the progesterone is at the bottom.
Yeah, so that's funny that you said that, because that's my doctor. I had asked him to take some tests, and he said, if you consider day one, the day that you start your period, he said that the time that we want to see your progesterone the best is day 21 on your cycle in the luteal phase, to see how it is.
Yeah. We that's when we expect it to spike. So if it's moderate, low, or maybe the spike is happening too early or too late, then that's basically going to throw everything off for the following cycle.
So do you suggest that if someone does want to take their hormones, do you say, okay, can we do it now? Let's just say, pretend they're on day 7 of their cycle. Would you be able to take it then, and then also check just the progesterone on day 21? Or would you say just don't take any blood work until day 21 and let's see what that is?
I would say it depends on what the priority level is for them in terms of if it's really menstrual, premenstrual, perimenstrual issues that we're working on. If that's a woman's primary focus, then I would probably hold off and do everything around day 21, because that's going to be the most impactful for us and give us the best information for where we want to adjust our treatment plan going forward. But if that's just one slight, not really a high priority, but it would be great to get just generally long-term for maybe indirectly some other issues going on, then that's where we can sort of put it off and take it later.
So would you say the biggest thing that needs to be on that 21 day is what your progesterone level is? Because the rest of them are going to stay around where they need to. But the biggest difference is if you do it on day 21, that's when you're going to see your progesterone spike.
I in my practice, I'm most commonly tracking around that time frame, but there's a couple of other things. So if we're checking other hormone, just normal fluctuations, what we're wanting to see earlier in the cycle, sometimes that happens. Just in my practice, I'm not checking that as much. Doctors who are focusing more on fertility, maybe doing a blood draw on day 3 and another one on day 21, for example. Another thing that comes to mind is some women say, I have no idea when my period is going to happen. It could be early one month, late the next month. I have no day 21 that I can plan for. And whether that's a blood test or a urine test, we kind of got to figure out what day we're going to be doing that. So I would say that actual day one itself can be a little bit flexible. We should be able to get a good information if it's maybe 1 or 2 days earlier or later. And then sometimes we just really, truly don't know. A lot of my patients are in that perimenopausal timeframe where the periods are going shorter and then they're going longer again. And so we basically just take our best stab at it and then match up to what happened. Okay, when did your period happen? And did we capture that test a little earlier or a little bit later than ideal, and then match up what those results are to where she actually was in her cycle?
So I want to talk about extended fasting for just a second. And one of the things that I think is really so true, and I never knew it until probably just a couple of years ago. I wish I would have known it a little bit sooner. But the time of the month it is for your menstrual cycle makes such a massive difference on whether someone wants to do an extended fast. So let's say they decide, hey, I want to do a 24-hour fast or a 48-hour fast or even a 3-day fast. The times of the month for me that it seems like it's the easiest are day 5 of my period, and then days like 15 to say 21 for me. That just seems like it is. Could you talk a little bit about why that would be, or if you feel like there's other times where you feel like these are the best days that you could do an extended fast because of your hormones? If they were all in alignment, that's another key.
Sure. Yes. And are we using fasting as an interventional tool to help with supporting where we're wanting to adjust the hormones? I'll say that what you're saying makes a lot of sense in terms of what we know with the estrogen kind of coming up and then down in that first part of the cycle. So your body's built up all the estrogen that it needs, and is transitioning down in that day 5 to 10 range. So you have a good amount of stores there hormonal wise, and your body isn't expecting a high progesterone yet. So what you're working from is really good hormonal reserves relative to what your body needs. And we know how good fasting, and whether that's intermittent fasting or shortish, prolonged, like between 1 and 3 days, is for helping the interplay between insulin resistance, if that's present, and estrogen. Very close interaction there. So your timing makes a lot of sense there. And then later on in the cycle, that's when the progesterone is coming up. And then 21 to 28 days is when that we're kind of on the down slope of the roller coaster of the progesterone, so to speak. So we've kind of built everything up and can kind of live off of that for a while in a matter of speaking.
Hey guys, I wanted to tell you I'm offering a free weight loss virtual Bible study. Now is the perfect time to focus on understanding true hunger and fullness and learn what the Bible has to say about it. All you have to do is go to chantelrayway.com/Bible study. After you sign up, you'll receive a 6-week Bible study video that you can watch on your own, or you can get a small group of people and do it together. That's chantelrayway.com/Bible study for your free 6-week Bible study course. So those are the right times that you should fast? Like those are the ones, I mean, I just know when it is the easiest for me, but does that match what you would say the hormones are doing?
Yes. And the other end of that is that I would say that for a lot of women, they're noticing a difficulty if they're trying to fast like right during their period and then also right before. And it's just that our internal environment is more sensitive to what's going on with the estrogen when the period is actually happening, and then what's going on with the progesterone right before the next one happens.
So one of the things that I get a lot of questions on, and I think it's because I said it one time in my podcast, so people have heard me before. And one of the things that I'm seeing is a lot of people are getting massive headaches the first day that they start their period, and then the last day they're ending their period. One thing that I've done is I've just started taking progesterone cream like on day 15.
Mm-hmm.
And that seems to help with that. But can you talk about, number one, why are you getting those headaches that day before? I mean, I would get, it hasn't happened in a while, but I would get to the point I would have such a bad headache that first day of my period where I was right about to, that I would throw up. I would get a migraine headache to the point that I would throw up because I was that sick, and it hasn't happened in a while. But could you talk about that for people who are suffering that?
Yeah. So there can be the full spectrum from a little, what we'd call tension headache, like, oh, this is bothersome. I need to limit, screen time or something like that, all the way to a full migraine, light sensitivity, or got to close myself up in a dark room. Women can kind of experience anywhere along the spectrum. And that if it is associated with the menstrual cycle, with hormone fluctuations, I would say like within like 1 to 3 days prior to the period into it, maybe 1 to 3 days, that's very common. And the reason for that, kind of what's going on, is that I would be suspicious, just based on the many women that I'm seeing with this, and then matching up to what their hormone results looked like, is that there was perhaps a propensity towards the estrogen excess or a lack of the progesterone. That's the most common ratio that I see there. And as we all know, going through menstrual periods, not every single one is the same. So that imbalance, that ratio, that dominance, maybe it's pretty balanced some cycles, and thus a woman would not be maybe experiencing much or any headaches, and then others are much more extreme. I take a look at seeing, I guess what I would be looking towards is seeing that the estrogen isn't too high and seeing that the progesterone isn't too low. And on a physiologic kind of anatomic basis, that unbalanced, I guess the progesterone and the estrogen exist in this nice balance. They counter each other. And when that teeter-totter is skewed and there's a little bit excess estrogen activity, it is more constricting to our blood vessels, such as the small blood vessels in our head.
Let's talk about, this question is from Amy Mays, and she asks, why does menopause cause weight gain?
That is a really good question. And I love digging down into the rabbit hole of what's going on with our hormones. And the biggest interplay that I see with that is going back to something I touched on really briefly, which is insulin, what's going on with insulin and what's going on with estrogen. So speaking a little bit about insulin, it's the hormone that regulates our blood sugar. It does a lot of other metabolic activities in our body. And we all exist. This is another type of spectrum on a spectrum of insulin sensitivity to insulin resistance. And that there's a strong component of our just genetic predisposition there, kind of looking at family history, how insulin sensitive or resistant someone is. And then as we all go through time without any careful attention towards correcting or addressing or reversing this, we will all become a little bit more insulin resistant over time. And that trajectory is really accelerated as the estrogen drops off through the perimenopause and at that menopausal shift. For all women, the estrogen drops. For some, it's moderate, and for some, they're left with like 1% of what they had previously. So the presence of that estrogen earlier in life can, for those who are predisposed to insulin resistance, keep that in check. And then it's like that safeguard goes on retirement and lets the insulin resistance sort of run wild, and that creates sort of this metabolic environment for someone to be way sensitive to their carbohydrates that they're taking in dietarily that they weren't previously. And for these women, it seems like whatever they're doing, they're gaining weight. They're eating well, they're gaining weight. They are continuing to exercise and they're gaining weight. And that's because of this metabolic change in the background.
Okay, this next one is from Barbara Morgan, and she says, I'm interested in learning about how intermittent fasting might impact already elevated cortisol levels. I know everyone's different, but I don't know if intermittent fasting has made my cortisol levels worse. I don't think so, but I'm doing a lot of things to lower it. But I've listened to some different podcasts, and they've said that actually intermittent fasting can exacerbate it. But I know that intermittent fasting can be a stress on the body, but I also don't want to affect my cortisol levels. What are your thoughts on this?
That's a great question, because I think some people could take intermittent fasting and prolonged fasting into a place where it is stressful on them. And I think this all just necessitates a lot of kind of self-care and checking in. And it sounds like this lady said she is aware of her stress, kind of self-care, taking good care of herself. And I would say, how does it feel? How does the intermittent fasting feel? If that's often where someone is starting before they're going into the more prolonged fasting, are they feeling good? Are they feeling very challenged and sort of fighting against something? I would say for a lot of patients that I've heard, when they're getting into intermittent fasting, they like it. It's actually a stress reliever. They're like, great, I didn't realize I don't have to plan for as many meals, and I feel good, and I don't feel hungry, and I'm sleeping well. Okay, I would say for those people, and yeah, I've run their hormones on those urine hormone panels. They're checking adrenal hormones as well as the sex hormones, the estrogen, progesterone, and testosterone. So we can see how those are changing, but I would say kind of just check in with yourself. So what I was explaining is someone that I wouldn't expect that they're putting a stress on their body, they're elevating their cortisol, versus if someone is sort of going 0 to 60 and doing a pretty radical change overnight, noticing that they are shaky, having trouble sleeping, just feeling stressed out. Then I would say kind of just take a close look at that and see if you can't take smaller steps that feel a little bit more comfortable. Because yeah, I think someone can take it too extreme too fast, and that could be potentially stressful. But for a lot of people, I don't see it that way.
Hey guys, one of the things that will take your weight loss to the next level is coaching. You can either work one-on-one with me or one of our certified private coaches. If you'd like, you can schedule your free call. It's a 10-minute strategy call just to see if coaching is going to really take you to the next level. Don't just take my word for it. Listen to this recent review a happy coaching client sent in.
Thanks so much for your help and guidance. I never could have done it without you.
The other thing is listening to the audiobook. Listening to the audiobook and getting the video course that I've done, people are seeing dramatic results. If you just listen to the audiobook 30 minutes a day over and over and over again and get the video course, go to chantelrayway.com and check out the video course. You won't be sorry you did. Okay, this next question we've kind of talked about a little bit, but we can expand on it. This question is from Shayna Carlson. She said, my doctor says that women should fast in certain phases only, and that she recommends that they fast during the follicular phases only. She said that they shouldn't fast during the ovulation and menses, as our bodies don't need additional stressors when they're trying to make hormones. What do you say?
Parts of that I can understand. Parts I would like to address. So we are all making hormones all the time. Every day we're making hormones. So whenever you're fasting, that day you're also going to be invariably making hormones of one sort or another. The menses itself does occur during the follicular phase.
Well, let's explain the phases for someone who's listening to this and they're new. Like, let's just break it down more simple, and let's go over the different phases and then where you recommend for people.
Okay. So everyone, like, take out your phones where you're tracking your period in your period app. Like most women are doing that now. Like, open it up and take a look at when your period last started, not ended, but started. And we're going to call that day 1. Every time you start your period, we're going to call that day 1. So day 1 through roughly day 14. So that the week of the period, and let's say you have a period for 3 or 5 or 7 days, whatever it is. So that week plus the following week, that's what we call the follicular phase. And then about day 15 is through 28. If you have a 28-day cycle, we call that the luteal phase. As we know, all women are just a little bit different with slightly shorter or longer phases, but roughly for a 28-day cycle, we break it in half and call the week of the period, and the next week the follicular phase, and then the last 2 weeks the luteal phase. And to tie that into when someone should or should not fast. Like we've said, maybe the slightly more extended into the 1 to 3 day fasting, I would say that generally women can feel pretty good and like they're tolerating it, like it's overall a benefit to them in that week after their period. And that some women are definitely feeling pretty sensitive, like they're just not feeling like they can tolerate it, like they're having a beneficial experience potentially in that luteal phase. But that's really more for the extended. I would say for intermittent fasting, I generally don't see a strong, I guess a strong sensitivity to it kind of through the cycle. I see generally that women tolerate pretty well, just having like an 18-6 sort of a intermittent fasting, no matter where they are in their cycle.
So just break it down by day, go to day 1 to day, like, I guess, do you base it on most women having a period for 4 days, 5 days, or?
I would say 3 to 5 is pretty typical, pretty normal. Up to 7, that's getting a little bit long. And then if it's more than 7, then we're definitely thinking like there's some sort of a hormonal imbalance that just isn't cutting that period off at the time that it should.
So if we start, because if you say the menstrual phase, right? So that's day 1. Mm-hmm. And then you're saying, so day 1 to day 5 is considered the menstrual phase. Is that kind of what you're saying? Okay. Then it goes into the follicular phase, right?
The menstrual period actually is part of the follicular phase.
Okay. So you put the menstrual phase and the follicular phase together.
Yeah.
And then you say, okay, then what days are you considering the ovulation phase?
Well, on a technical level, that's when a woman ovulates, and that can vary a little bit. I would say day 10 to 14 ish. Some women have symptoms, and they actually can kind of perceive when they're ovulating. Maybe it's a little bit of pinchy, cramping down in the lower abdominal area on the left or the right. Another symptom that some women notice, especially if they're trying to conceive and are really focusing on their ovulation cycle, is what we call cervical mucus change. So that's just vaginal discharge changing in its consistency. A lot of women just have no idea. They don't feel anything. They don't notice anything. Maybe their app pops something up saying you're ovulating today. But yeah, that's around days 10 to 14 ish.
And then the luteal phase is then considered day 14 until day 28.
Yeah, I would say like 15 to 28, just so we're having kind of a clean 2 week and 2 weeks phases there.
And that's why I don't feel like you can talk about, I don't feel like you can talk about when to fast based on whether it's your luteal phase, follicular, like it has to be based on the days. Because if you think about it, if the luteal phase is considered day 14 to day 28, well, I do great fasting from day 15 to say day 21. But then starting at day 21, I don't do good fasting. So if all of those days are included in the luteal phase, you can't talk about it as a phase. You have to talk about it as days instead of the phases.
Yeah.
Do you agree with that?
And I think you're getting to something even kind of below that, which is like the phases is just sort of our way of differentiating like first half versus second half of the cycle. But each week there's its own, there's differences in what our bodies are doing, just generally in terms of building up uterine lining and having a period, but also the hormones underlying that. So like early and late follicular, early and late luteal, there's difference. There's big hormonal shifts happening.
So let's talk about somebody who is in the menopause stage. So for them, does it matter when they are going to fast?
I don't really see any changes. How I explain this, because this is just what I see working with so many women over time, is that so during the years that we have our periods, there's hormonal shifts, and then during the perimenopause, like those hormones are still cycling and they're going down, and in that menopause, postmenopausal state, there still can be a little bit of shifts there, especially in, I would say, like early postmenopause. So maybe the period stopped a year and a half, 2 years ago. Some women are still noticing a little bit of cyclic hormonal response, maybe a little bit of breast tenderness, a little bit of moodiness that seems to come and go on a monthly-ish cycle there. And but generally speaking, as far as it comes to tolerance and benefits of fasting, whether that's intermittent fasting or more prolonged fasting, I don't see the big I would say swings in it that I do see for women earlier in life.
So let's talk about estrogen dominance for just a second. I feel like that's kind of the new buzzword around town. And what are some of the causes of estrogen dominance, and what are things you can do to get rid of it?
Great. Okay. Well, how much time do you have? That's a big topic. Where does it come from? Well, we do know that certain estrogen dominant conditions are familial. So part of that may be just someone's family history, their genes. We certainly know there's a lot of environmental impacts on our own hormones. And unfortunately, that just seems like something we have to be more and more careful about over the years. So I would say like a big thing is plastic compounds and other what we call xenoestrogens. So these are compounds that are created for whatever sort of manufacturing reason, and that our interaction with them has an impact on our hormones. Plastics is a big one. There's a lot of different compounds in plastics that can influence what our estrogens are doing in our body. And it's called xenoestrogens because the xeno means sort of outside of our body. And it having a xenoestrogenic action means that it's influencing our actual hormone receptors, even though it's not true, pure estrogen as our body makes it. It's sort of kind of mucking up the picture there. So being aware of what compounds are storing our food, are in our laundry detergents, topicals, makeup, kind of any of those can have compounds that can be estrogenic. I like the Environmental Working Group's website for checking your own just detergents and home care items and really anything like that. And they have a huge directory where they can say like, what are in these and do they have any known interactions to our health? Just because they create new and different kinds of stabilizers and other things. So every single year, it seems like there's new things to watch out for on that end. And I'm just talking about that because it sort of adds to the issue. If someone already has a slight estrogenic imbalance, a little bit more estrogen dominance, those kind of factors are going to be pushing it even further. On the other end of the spectrum, so that's kind of too much estrogen activity coming in. The other element are the estrogen that we want, that our body is trying to get out, actually getting out. And so differences in liver processing and kind of packaging up all those hormones and getting them into the intestines and getting them out of the body. For some people, that's more of a compromise. And certainly if there's digestive issues, sluggish digestion, constipation, those kind of things, like those hormone packages that our body is trying to get out just won't as readily, won't as quickly. And those packages can then open back up and recirculate in our body.
What is your thoughts on using DIM? I have on chantelrayway.com and things I love. I have a supplement called DIM on there. Mm-hmm. What is your thoughts on using DIM to help with estrogen dominance?
I like it because it is just helping support how our hormones are breaking down. So it's sort of like it's just encouraging that less inflammatory estrogenic activity in sort of, I think, like a nice, gentle, supportive way. It's not blocking anything. It's not forcing our body to do anything, and it's not even hormone containing. So it's just sort of encouraging, like, hey, estrogen dominance, would you like to get broken down in a less problematic way, and then so the body can kind of take care of it and eliminate it.
Let's talk about the effect of your hormones on your joints. So I have in my right wrist, just randomly, my right wrist, it hurts to the point like I can't, like this side I can bend it, this side I can't. So I can't do push-ups. I can't do anything that kind of pushes that like that. And it's just so random. Like I didn't really do anything to hurt it. Do you feel like hormones have a play in joints? And have you seen women just with random joint issues that are kind of unexplained? They didn't do anything, they didn't injure it in any way or anything like that?
Yes, and yes. So of course there can be other reasons for a chronic joint lingering pain or achiness or something like that. There's other inflammatory or nutrient deficiencies. There's certainly other things that can be going on, but yes, specifically to hormones, I will tell you that I've seen women that they can be migrating joint aches and pains. It can be in one spot. It can be sort of in one spot and then slowly, and now here, and now the hip, and now the shoulder, like it just seems to be growing. And without any other kind of intervention, because maybe that was in the background and they mentioned it, but it wasn't a top priority. We were focusing on something else hormonally related, their fatigue, their hair falling out, their low sex drive, whatever it was. We were focusing more on hormones, identified a hormone deficiency, helped boost that activity, and then the joint pain went away. So I've seen that time and time again. And I will tell you the top 3 hormones that I've seen, like we treated a hormone deficiency and their joints got better, is thyroid, testosterone, and estrogen.
Awesome. Anything else that you can think of that you've seen kind of the biggest change with people of how they feel? So you say, people come see me and their hormones are imbalanced. This is kind of the protocol we do, and this is how we help them to feel better.
Gosh, yeah. I mean, I love working through this process. I love investigating it because we're all different. So for one person, it may be getting just a joint biomechanically, getting it moving, replacing a nutritional deficiency, adding in some anti-inflammatory nutrients. But I see it really powerful the interplay there between getting someone's body in an optimal state and getting their hormones in an optimal state, because there really is this feedback loop between our hormones and our joints and our muscles. And I'm talking to patients all the time who are coming to me, quote unquote, just for hormones. And I say, and how are you moving? Are you moving? What is your activity like? And really encouraging them to kind of step into that, to get and stay strong, as I'm often saying, because starting from a place of very little muscle mass, very, very little strength, and then building up those muscle fibers, building up that muscle integrity kind of completes the loop to then balance out our own hormones, estrogen, testosterone, so that we can have a really nice positive snowball effect instead of a negative snowball effect of things feeling weak and tired and joints hurting and kind of the typical aging process. We can intervene there and have everything working in our favor instead of against us.
I know one more thing I want to talk to you about is regenerative injection therapies. I know there's two primary types, and I'd like for you to talk about those and what kind of experience you've had with that, and where do you see when people come to you, how many times do you have to do it, and what are some of the things that you've seen treated the best?
Sure. Yeah. So this is another passion of mine because it kind of helped me put in my last missing piece of my own knee surgery and injury and lingering issues with recovery. So with regenerative injection therapies, the idea behind that is the injections are going specifically to the site of the chronic joint pain, injury, instability, degenerative changes there. And the injection is really telling the body, sort of tricking it pretty much to say, this is actually a new, fresh injury. So come on in, immune system healing processes that we naturally have within us, and reheal this tissue. And the two main types, the ones that I do, are Prolotherapy and Platelet-Rich plasma injections, or PRP. And so both of those exist on a spectrum of they're doing that's what we call stem cell migration signal, which is that sort of chemical signal to tell the body it's recreating the communication, saying this is a new injury, come on and heal this area. And I see a lot of different types of osteoarthritis or degenerative joint disease. So in knees, hips, low back, shoulders, those respond really well. Sports injuries, lingering issues from like a car wreck. I would say that prolotherapy is the predominant one that I'm doing, and it's very great for just kind of supporting ligament and connective tissue recovery in that area. And then sometimes I'm going in later with the PRP, the platelet-rich plasma injections, just to address a specific partial tear, for example.
Awesome. Well, thanks so much for being with us today. Tell listeners where they can find you and where they can follow you.
Sure. So I am on social media, Facebook and Instagram. And on both of those, it's Dr. Angela Cortal. So it's Dr. and then Angela Cortal. And my website is drcortal.com, drcortal.com. And if you are a ebook or paperback type of reader, if you'd like to read more on this, my new book is up on Amazon, so you can search my name or the book name of Younger Joints Today and find me on there as well.
Awesome. Well, if you have a question, just like we answered today, we'd love to answer your questions. Email us at questions@chantelrayway.com. Stay tuned, and we'll see you in just a little bit. Bye-bye for now.
This has been a Sempronto Media production.